So today what I'm going to do is what I'll call both an addendum and a preamble to much of what I've said about assessment before. So one of the things that I want to put out is that much of what I speak of is making what is implicit in many people's practices explicit, and essentially providing a framework that is spoken. So to take something that many people do, whether they're aware of it or not, and to make it explicit so that you have a framework on which to build. Now, with respect to assessment, what I want to add to the concepts that I've put out, so essentially, macro identifies micro, or large motions identify smaller problems because the large motions are made up of smaller subcomponents. The idea of patient active preferably before patient passive, as well as being organized, so have an organized approach. I want to add a mental consideration or a cognitive consideration. If you think about the physical requirements for the patient to present themselves in your office, you will have essentially gone through a general screening process for what is more or less likely to be severe. So some things to consider. If it is required for the patient to walk into your office, the ability to walk, even to shuffle and do so with great difficulty, suggests that the patient is at least ambulatory. So that's a sign that the requirement for care is less emergent. If the requirement to present to your office requires changes in elevation with no mechanical help, by that I mean either a ramp or a set of stairs up or down, or even one step up or down. If they can do that, then that suggests a fair amount of mobility that is unrestricted in the leg, generally speaking, as well as enough strength to do that. Again, they may do it with great difficulty. More likely than not, if they're doing it with great difficulty, shuffling with a lot of pain, you're going to be able to identify that upon greeting them and taking them from the entrance to the office to your treatment room. The other deal is to consider their ability to actually get onto the table or onto the treatment surface, whatever it may be. If they can go from a relative standing position, even if it is quite difficult, to sit on the treatment surface or to lay on the treatment surface, even if it's with great pain, again, it reduces your belief that the requirement for care is emergent, and that makes them more likely to be amenable to hands-on osteopathic manual care, because this is not something that is, again, emergent, requiring emergent medical care in the form of surgery or something else. So the simple thought and the simple consideration of what are the physical requirements for the patient to present themselves for care can allow you to understand the severity of the condition that they present with. You're going to have to pay attention to them as they enter the office or as they enter the treatment space, because they'll show some of the ambulatory concerns or considerations. They'll show a fair amount of visual and auditory pain, should it be present. Or if they just walk right in and are able to sit on the table and have a smile on their face, then the nature of their concern is likely to be less severe in its immediate nature. It doesn't mean that it's not severe in its chronic nature. It just means it's less severe in its immediate nature. So you're considering, again, the physical requirements to present to your office, because all of our offices are different. Some offices may be completely level with the ground floor, with the street. There may be no more than 5 feet from the door to the treatment surface. There may be 20 feet, there may be 30 feet, there may be 20 stairs to get up or down to your office. Your office may have stairs, but it may also have an elevator. You would want to figure out if the patient is unable to take the stairs and requires themselves to take the elevator. So again, lots of talking just to consider your physical space, your office space, your treatment surface, and the physical requirements for the patient to present themselves for care. If they are easily able to present themselves for care, then immediate nature of the issue is likely less severe. Again, it doesn't mean that it's not chronically severe or that it's even not acutely severe, because it may be, but it may be short of the requirement for emergent medical care. So again, the all-encompassing concept here with respect to thinking what you're possibly considering what you're likely to find, or the severity of what you're likely to find before you actually begin your mechanical assessment, is what are the physical requirements for the patient to present themselves for care, and how have they shown ease with doing so or difficulty with doing so. So that is just something to consider with respect to the severity of the case that is presented to you in that moment. Again, not the severity over time, not the chronic severity, and sometimes again not even the acute severity, because it might be quite severe, but if there are physical barriers that make it a little bit more difficult to present to care, then even if they are in quite a bit of acute pain, they were still able to make it across those barriers that would be difficult for somebody who would need emergent care. So again, the overall conception: what are the physical requirements for the patient to present themselves to care in your particular office space? And that can give you some sense of how bad the case is likely to be in that moment, and whether or not you should begin considering the possibility of emergent care or not.